Good afternoon. My name is Mwate Chaila, and my presentation is based on a primary screening tool that increased yield in HIV positive adolescents aged 10 to 14 years old in a community intervention. I'll give experiences of the HIV Prevention Trial Network 071 PopART study in Zambia. And below these were funders, were primarily funded by PEPFAR, 3IE, the Bill and Melinda Gates Foundation, and the NIH. The other component of the study, which is the PopART for Youth study, where my presentation is based, was funded through a UK-aid funded program, the Evidence for HIV Prevention in Southern Africa, or simply EPSA. So background of the party study. So this was the PopART for Youth study that was nested within the HPTN 071 PopART trial. The PopART trial investigated if a combination HIV prevention package, including universal test and treat, could reduce HIV incidence at community level in Zambia and in South Africa. While the party study's primary outcome as a nested study was HIV counseling and testing in the previous 12 months in adolescents. So the study was in Zambia and South Africa and was conducted in a total of 21 communities. 14 were in Zambia and 7 were in South Africa. What did the PopART intervention have? So it involved community HIV care providers called CHIPs who moved in communities door to door to offer information on HIV testing, counseling, VMMC, tuberculosis, and STIs. They offered HIV testing in the household people, and those that accepted were tested, and those that tested positive were linked to HIV treatment services regardless of their CD4 count. Then the males that tested HIV negative were linked to VMMC facilities. The party study was implemented in a 3-phased approach. The first phase involved implementation of the PopART study in its current state, in its original state. And the second phase included addition of additional implementation of additional youth targeted interventions. And the third part involved conducting of a cross-sectional survey, which showed that the interventions improved the knowledge of HIV uptake, the knowledge of HIV status in the adolescents. So we followed the adolescents as indicated earlier, door to door in the community. Assent and consent were provided by the adolescents and their guardians for them to participate in the study. Then HIV education was offered as well as HIV testing. Further, we wanted to see if a screening tool that was used in the clinical settings of Zimbabwe could effectively be used to identify and diagnose adolescents who are living with HIV in the community settings. So we therefore administered this tool to the adolescents in that age group. So this tool was, as indicated, was used in the clinical settings of Zimbabwe. We adopted 4 questions, and the first question was history of hospital admission, recurring skin problem, poor health in the last 3 months, and death of one or both of the natural parents. If an adolescent answered yes to any one of these questions, we classified them as being at risk of possible HIV infection. We, however, went ahead to test all the adolescents, regardless of their risk status. What did we find? We found that of the nearly 34,000 adolescents that we approached, about 4,000 of them, indicating an 11.6%, were classified to be at risk, meaning that they answered yes to one of those 4 questions. And among them, 181 indicating a 4.6% self-reported to be HIV positive, compared to those that were reported to be not at risk, where only 0.8% of them self-reported to be HIV infected. When we offered HIV testing to those that were eligible for HIV testing, we saw an acceptance rate of about 81% from the at-risk group, and 45 tested HIV positive, and which was a positivity rate of 1.5%. This was compared to those that were not at risk, whose positivity rate was at 0.3%. So from this, we're able to see that the tool was able to identify about 5 times more positive adolescents are compared to those that were not at risk. So in conclusion, as we saw, the majority of our adolescents were classified actually not to be at risk. And as indicated, they were 5 times more likely to test HIV positive in the at-risk group compared to the not at-risk group. So this tool was easily administered by the community-based providers, and indeed was acceptable by the community. Further, we do realize that this tool may be used in community settings for facilities that are not, or for countries that are not implementing universal test and treat for this age group. And we also realized after we did additional analysis that despite the higher yields by using the tool, we still missed out some adolescents, and therefore this tool should not be a replacement for universal test and treat. So this picture just shows the adolescent that we worked with that formed part of the body, and the people that we worked with to conduct this study. Thank you.